Hello, everybody. This is Dr. Albright. He's going to talk to you about what he does. Dr. Albright, have some fun.
All right. So, like I said, my name is Jay Albright. I'm the surgical director of sports medicine at Children's Hospital Colorado, as well as a associate professor at uh, uh, University of Colorado Department of Orthopedics. Um, the I love giving this talk, and so I love the idea of potentially inspiring one of you, if not many of you, to do maybe not exactly what I do, but at least something in the medical field related to sports medicine. There's sports medicine is a very broad and vast, really profession, and there's many entry points into sports medicine. And I think that you may find one of these, including what I do, to be intriguing and potentially something that you'd like to do. So, what do I do? Well, I'm a surgeon. So, how did I get to Colorado? Well, I'm originally from Iowa. I am a product of a public school, just like you guys are. Iowa City West High School. A little different than your high school. When I was in high school, it's not true this anymore, but when I was in high school, there was a pasture next to my high school, to the west of my high school, because we were technically on the outskirts of town. And there was a bunch of cows there. So when the wind blew, it didn't smell very good, especially in the summer. But then I went from there to University of Michigan, where my son just started in the honors program. He graduated from Rock Canyon. Don't hold that against me. I went there just to make my brother mad because he was a Michigan State person at the time. And then after that, I went back to Iowa City to do medical school. So if you think about that, that's 4 years of college and 4 years of medical school. To the right, the picture is me doing surgery with my GoPro on at the time, just so I can show what I do. And then after medical school, so 4 years of medical school, then 5 years of orthopedic residency. That was a total of 9 years in Iowa, back in my hometown. And I did 2 extra years after residency, where I did a year of pediatric orthopedics and then a year of sports medicine in Cincinnati, Ohio. From there, we moved all the way to Orlando. So I've been all over the country. We literally lived about 10 minutes north of Disney, so I could see Disney fireworks pretty much every night that they had it. That was kind of cool, but I don't need to see fireworks anymore, really. And then after, so if you think about what I do, that was about 15, 16 years ago, where I started in Orlando. But according to my kids, I work too much, work all the time. According to my wife, I pay her debt to society. In other words, what does that mean? Well, I've had the fortune of working in places where it doesn't matter where you come from, who you are, who your parents are. I'm going to be able to take care of you, and I'm going to do that the same way with every patient, no matter what. According to my father, who is an orthopedic surgeon, I don't do enough, at least not yet. He helped train me. He's been at the University of Iowa for 48 years now. He taught me a lot of what I know, and has given me a lot of passion in my life and career for orthopedics, at least. So I owe him a lot in my life. In reality, I take care of conditions that affect athletes and kids. I do non-operative and operative care of sports injuries, as well as other traumatic injuries, anything from knees, hips, shoulders, elbows, ankles, fractures, back pain, back issues, etc. Anything musculoskeletal, I pretty much take care of. So about a little over 7 years ago, when I was I was elected or selected to represent the United States as a traveling fellow for our orthopedic sports medicine society here in the United States, to travel to China and Japan. I spent nearly 4 weeks traveling all over China and Japan there, with with 3 other orthopedic surgeons. And while I did that, my wife moved 2 dogs, 2 children, and 2 cars all the way up to here in Colorado. So I now work here at Children's Hospital Colorado. There's actually 16 pediatric orthopedic surgeons. There's 5 primary care sports physicians, 1 full-time sports surgeon, and 1 of my partners who's part-time. She does half-time hip and half-time sports, but it's really all sports hip. So she's kind of really 100% sports. And then our sports team, we see actually now 1,400 or 14,000 patient visits a year. We take care of at least 14 high schools, actually now 5 soccer clubs, lacrosse club. We actually have 29 partners in total that we help and partner with, and actually including now Cherry Creek schools. My adult partners in our team are able to help take care. These are kind of things that I get to see. Down to the left, I would normally ask if anybody could guess what that is. 1, it's a leg, but 2, it's a injury to young person's leg from a propeller. So if you think about it, a propeller, our body is about 70% water, and propellers propel us through water. So if you think about it, as a blade spin, they don't really slow down as they hit something like flesh. They do slow down when they hit something more rigid like bone. But this young person ended up with a few surgeries. And then on the right is, I usually use a scope and usually use small incisions. This was someone else's previous surgery that I was fixing. And thus I used their previous incision. So I didn't make new incisions, and that was a little bit bigger, and that's a knee. So other things I get to do, I get to kind of not really invent things, but I get to try to progress medicine. I teach residents, I teach fellows, I teach med students, I teach PA students, PT students, whoever really wants to learn orthopedics and sports medicine, I teach. I have had, once you graduate from high school, because of restrictions from children's, after you graduate from high school, you can even shadow me in clinic or in the OR, but not before you're out of high school because of that. So one of the major things that I do is I take care of athletes with ACL tears. So if you tear your ACL and you're my age, one, there'll be a debate on whether you should even do surgery, because I don't need to go ski like your teacher, Mr. Stirrup, has on his screen right now. But I like to, so maybe I do need an ACL to do that. However, someone that's a youth athlete or a high school athlete, in order to go back to athletics, you only have about a 10 or 15% chance, at least in the United States, of being able to go back to something like football or basketball or soccer or any other cutting or twisting sport without an ACL. So the other thing that's a problem is that kids under the age of 19 obviously are more active than older people, such as myself. And so the amount of times that you're going to try to tear your ACL again is more. And so until recently, we had not been able to really be able to match the success rates that we see in adults with ACL reconstruction in the child or adolescent population. However, about 13 years ago, I started using this quadriceps, which is part of the front of your thigh, quadricep mechanism, the thing that makes your knee extend or straighten. I started using a sliver of that with a little piece of bone from the kneecap. It's been done before, so I wasn't the first to think of it, but it was done in revision cases. So if someone did re-tear their ACL, someone like me would use a quad potentially to place a new ACL. I started using it in kids because I was unsatisfied with the high failure rates in kids. So to this date, I've done somewhere around 1,000 of these probably actually more than that, somewhere around 1,100 or so of these surgeries with this graft, and we have somewhere around a 4% failure rate, which approaches that of adults, and actually equals that of adults in a lot of respects. And it's about somewhere around 7 times better than the other grafts that people had previously used for kids. So we take it through a small, so there you go, there's in the upper left corner, you'll see the sort of representation of how we take it through a small incision. Upper right is actually taking it, and then we get a graft that's about 6.5 centimeters, so a little over 2 inches long. This is a video of sort of other things I get to do while we're in surgery. I use a camera, so this is through small incisions. This is a meniscus that I'm pushing back. It was torn and flipped into the front, so we get to use this types of things to push it back in place, and then as it sits back in place, now we can fix it. So once we fix it, there's multiple things we can use to fix it. With this is showing with a fine needle with some sutures attached to it, and then we can suture it, to the outside of the knee, or underneath the skin behind the knee in a way, and it's called the outside in technique. You have to make an incision in the side of the knee, but we can suture it multiple sutures and get it to be very stable in fixation. That'll allow it to have a chance to heal. So then we reprobe it and check and make sure that it's stable. And that looks pretty good. And then other options, we can use things called all-inside devices. Well, actually, before I do that, this is a method where we're trying to increase bone marrow, so stem cells, to leak into the knee to help that meniscus repair work. So here's a different example. This is the meniscus is right there. You can see is torn off of its attachment to the shin bone or tibia. And so we can fix that with sutures. And you can see that the rest of the meniscus there, when I pull on it, was stable, but here it's detached. Then we can use a special suturing device. It's like a sewing needle that passes through it, and it then captures it on the opposite side. We can suture that a few times and get a good hold of that meniscus. And then we need to figure out how to reattach it to the shin to get it to heal to the shin. So in this instance, what we do is we drill a tunnel through the tibia eventually, and we can pull that meniscus down to the tibia again and give it a chance to heal. So this is again trying to put our suturing device back in, suture it a couple times so we get good control of it, and then we can proceed with the fixation in a second. Let me speed through this. So you can see us passing the sutures down through the hole in the tibia that we made, and then we tie those sutures on the front of the shin to hold it in place. Then we can use an all-inside technique. So here's, instead of making bigger incisions, so this is similar to the very first one where we have a big tear that the meniscus is pulled forward too far. And you can see the red wall back there where it's supposed to be, so we can push it back. Or you can, pull it forward, and you can see that red wall where it needs to go or where it should be, so we can get it to heal. There's a little tear in the middle. We can't save that. It's called a radial tear, but we certainly can fix the remainder. So this is a device that is like a drywall anchor. We can push through the knee, and it ends up sitting behind the lining of the joint, and then just like a drywall anchor, and then there's one on either side with a suture attached between, and we can hold it, use that to hold the meniscus in place so it can heal, just like that. And then we can tie it or tighten it. It's already tied, and make sure that we get it tight so it can heal. So we'll move on. This is, so I do a lot of video game playing, essentially. I play video games every time I operate. I tell patients that we played video game for a while, which we're relatively good at. So here's, let me see if that'll work. So here we're taking that ACL graft and we're getting it in position so we can pull it into the thigh bone, and then we pull the other side down into the shin bone, into the tibia over here after we've made a place for it. And so there's the new ACL going across the knee, a little too close, it's hard to see, but there it is right there. And then let me move forward. So other things I got to do, I got to work with throwers and athletes that throw. This doesn't need the sound on, but you can see the tendon of this patient's triceps popping over the inside of their elbow, which was causing irritation of the ulnar nerve and making the hand go to sleep in the pinkies, and pinky and ring finger. And that every time he threw, it would snap, and that would cause him problems. And so what we were doing, what we end up having to do is end up having to trim out a little bit of that tendon and be able to stop that from happening. I get to work on shoulders, like I was saying before. If you can do this, one, you're odd, but two, it's just demonstrating how mobile your shoulders are and can be. It's a lot of range of motion, but the architecture of the shoulder also allows for it to be pretty unstable. It's likely the most commonly dislocated joint in the body, to be honest. It has things called dynamic stabilizers and static stabilizers. Dynamic stabilizers are your muscles. The static stabilizers are these ligaments and the lining of the joint, as well as some suction cup event. Or suction cup type of support that helps hold it in place. You got multiple different ligaments that do help hold your shoulder in place, but they only do that in sort of extremes of motion. And so there's and since you have lots of motion, they don't work 100% all the time. So those are the different ones. Your rotator cuff is the 4 muscles that are attached to your shoulder blade. They rotate your shoulder, and they attach to your ball of your shoulder like your shirt sleeve, like your cuff of your shirt sleeve, and that allows to pull the ball of your shoulder into the socket and hold it stable. So your bigger muscles, like your deltoid and your pec and your latissimus dorsi and your trapezius, can use your arm in space, such as throwing a ball, shooting basketball, anything like that. When you dislocate, such as in the lower left, you end up where the ball comes out from the cup and hits into the front of the cup. When that does that, you end up with this dent on the ball, a lot of the times called the Hill-Sachs lesion, which you can see multiple things can happen. You can have a dent in the back of the ball, like up in the upper right in the back. You can have this little triangle right here. This black triangle should be down here, just like it is on the back side. So this is called a Bankart tear. You can also tear off the capsule from the ball side instead of tearing on the cup side, and that is what's called a Hagel lesion. So this is another fun surgery for me. But we do this arthroscopically with usually patients sitting up. They get here you can see the anterior labrum, it's like a floppy edge of a suction cup is ripped off. And then you can also see the dent in the back of the ball. So we can fix the labrum by removing or freeing up that labrum from its usually scarring over the corner here off the edge, and we can loosen that up, and then we are able to pass sutures around that labrum, and then we can drill anchors into the bone. So here are the sutures around the labrum. We can then place these anchors and hold the labrum, which is this thing around the front and the back into place, which does a couple things. It acts kind of like the parking stumps in the parking lot with the railroad ties in them. It keeps your tires from rolling past it unless it goes up and over. which you shouldn't do. It's not good for your car. But it also creates that suction effect by having the floppy edge of the suction cup back in place. And so the combination of those two things can restore a patient's stability. The other things we got to do is, this is a kid, the hip is up to the left, the ankle's down to the right. What I'm holding there is the tendon of the patellar tendon down at the top of your shin and the front of your knee. This young person had tried to go up for a dunk, and when they tried to leave the ground, the quad muscle broke the tibia and pulled off the patellar tendon with a piece of bone, which is right under there as well. So that's the tendon, and there's bone attached, and that's where it belongs. So we put that back down and we put it in place. So that was a long-winded answer. I guess one of the things that I will go over too is that people ask how much I work or how many hours a week. It varies a little bit, but on average, I would say I work somewhere around 90 hours a week, either in the hospital, take on call, out on the field, taking care of kids, playing whatever sport, soccer, lacrosse, football, and I teach. And so I have one thing I will say is I have full respect for Mr. Stirrup, who gets to deal with you guys all the time. I usually teach with, usually in small groups, one-on-one, maybe up to 12 students at one time, except for national or international conferences where I'll be giving a course or a lecture on, upwards of 1,000 people, but that's only for an hour talk. And so for this, if it wasn't for my high school teachers encouraging me, I certainly wouldn't be where I am. And so certainly this type of class I enjoy talking at, because just like I said in the beginning, to be able to stimulate at least one of you to be able to think about doing something in sports medicine, it would be incredible. So what do? I help teach. I teach patients, parents, residents, fellows, medical students, other students, my kids, even, and other surgeons about how I do things, about the research that we've done to help try to advance medicine, advance sports medicine, and help take care of kids, take care of athletes in the best way possible. I help coach. Parents and patients in the process of the recovery, whether it's with the surgery or without, and how we're going to do it safest and best. I coach the residents and sometimes and fellows in their careers, as well as help medical students in their careers, writing letters, helping guide them, even if it's not orthopedics that they end up wanting to do. Hopefully I can help guide my children, in addition, into finding the career that they wish to do, even if it's not medicine, because that's not a requirement in my family, at least. It may seem like it because my dad is one and I am one as well. To go back and talk a little bit about the other fields of sports medicine, or within sports medicine, you have athletic trainers. I get to work with 36 athletic trainers on a regular basis. We have about 10 or so that are in clinic and or in the OR with me. And they help all of our Orthopedic Institute at Children's Hospital in clinic, seeing those 14,000 patients a year in sports medicine clinic. We have the rest of our athletic trainers are out in the community, either in high schools or in club settings or other settings where they can be used to help take care of athletes on the front line. So they're first usually to see the athletes in their injury. And they also work through the injuries themselves until they need x-rays or other things to diagnose it, if it's needed. And then help them on the other side with recovery and getting back, that final step to get back on the field or court or wherever, or ice, I guess. And then we have our primary care sports medicine physicians. They are pediatricians or family medicine or internal medicine or emergency medicine trained. and they also then do a fellowship in sports medicine, and then they help with regard to the overall health of each individual athlete, as well as diagnosis and treatment of non-operative orthopedic injuries. We have our physical therapists, our sports physical therapists, who help after an injury, after surgery, help return that athlete back to full function by training you with physical therapy exercises that you have to do on your own, as well as with a therapist. So it's kind of like your homework. You don't do your homework, not going to do very well in the class. In physical therapy, if you don't you do your exercises, your homework, you're not going to do very well at returning yourself back to your sport in a timely fashion. And then there's surgeons, which I just talked about, what we do, or what I do at least. I certainly, Mr. Stirrup, I'm happy to have students happy to be available if students have other questions or have any questions with regard to what I do, or how they get in touch with me, or any of that. I'm very happy to stoke any kind of thought process and dialogue.
What I'll do is I have a spot when I embed the video for the kids. They can email me or put in there a question, and then I can email you. And then when you get a chance, respond to that email, and I'll post it for the kids to see. So it's
perfect.
Thank you so much for being part of this much different approach to how this class is done. But
yeah,
it's